Hi, welcome back to the 5th week of Consider This, a new series where we simplify the science and public health around the COVID pandemic. I'm McDowell.
And I'm Heidi Beidinger, and we're co-hosting this new webinar series focused on the pandemic. And our guests today are Jenna Coulson and Alex Perkins, and both of them are epidemiologists here in the biology science department at the University of Notre Dame. As their titles suggest, they are here today to talk to us about the epidemiology of this pandemic, and we're going to introduce them shortly. But first, as a reminder, our goal for this webinar has always been to help our community build their understanding of public health and science as it relates to COVID.
Yeah, and we hope you're finding the tutorial videos that we provide informative. And if you haven't checked out this week's, our guests provided them this week, so you don't have to listen to me drone on about something. So please check those out. They've talked about some epidemiology concepts as well as modeling. I want to remind you that we're trying to answer all of the questions we don't get to in the live sessions, and they are posted on the website. If you have trouble finding them, pop us an email at consider@nd.edu and we'll help you navigate that. I also want to remind you all that we bring the experts in to give you expert advice, but the views presented are the views of our guests, Heidi and myself, and not the views or policies of the University of Notre Dame. And the information is not intended to serve nor be interpreted as specific health advice and to substitute for the advice of your own individual's health practitioner.
Yeah, so last week we had a really great conversation about the pandemic and athletics here at Notre Dame. We had the chair of the faculty board, Tricia Balia, and the athletic director, Jack Swarbuck, were with us, where we learned a great deal about what they are doing to keep our athletes safe. We learned about testing protocols and prevention protocols, quarantine and isolation. And if you missed it, don't worry, because we've got it posted to our ThinkND webpage. So now here we are in week 5 of our series. So let's introduce our guests. So cue the guests. Hey, hi. We're so pleased to introduce our show's guests today, Jenna Coulson and Alex Perkins. As I said, both epidemiologists here at the University of Notre Dame. And I'm just going to do a brief introduction of each of you guys. Jenna has a particular interest in the epidemiology of malaria, involving field and laboratory work with the International Center of Excellence for Malaria Research in Malawi and the Kintampo Health Research Center in Kintampo, Ghana. Alex's work includes the application of mathematical, computational, and statistical approaches to answer basic and applied research questions about the ecology and epidemiology of infectious diseases. Both of them are also members of the Ecke Institute for Global Health, just like Marianne and I are, and the Ecke Institute is also one of the sponsors of this virtual series. So thanks again, guys, for joining us tonight. We're so happy you're here.
Yeah, happy to be here.
Yeah, likewise.
Yeah, thank you very, very much. And Jenna, that's a beautiful sunset behind you. I think
I brought it just for you guys.
Thanks. So thanks again. We're super grateful to help us unpack some of the concepts behind epidemiology today. But Heidi and I always ask our guests to tell us a little bit about themselves, how you got here, what you do, what drives you. And an added thing this week is please tell us a fun fact about yourself. So Jenna, you can go first.
Oh boy. Well, for me, I was always interested in health, but when I was young, I thought that meant you had to become a medical doctor and didn't really know there were other options. And then I went to college and got introduced to the idea that there were all these other ways that you could actually approach the study of health. And epidemiology is a fantastic way to do it because it's so interdisciplinary by nature. You have to do a little bit of thinking about behaviors and a little bit of thinking about biology and how those things fit together. And so you get to use sort of all kinds of tools to approach interesting questions that have really big implications for people. And so for me, it means I get to do a little bit of everything and still study interesting and important diseases. And so for me, it's been a great career. Oh, and then I'm supposed to give a fun fact. Well, I was hoping for some superstitious soccer fans to pay me a lot of money, because in 2006, I was studying in Italy for 3 months and Italy won the World Cup. And then in 2010, I was doing malaria research in Ghana for 3 months and they got to the semifinals. And I was like, if I'm in this country 2 World Cups in a row and they win in 2014, someone's going to pay me the big bucks to fly to their country and that'll be great. But it didn't really work out for me, unfortunately.
That's a good one.
It is a good one.
Thank you very much. Alex, do you want to tell us about yourself a little bit?
Sure, I'd be happy to. So thanks for introducing me and for putting this series on in the first place. In terms of getting into science, I was always interested in biology and math. And when I went to college, I was trying to figure out what to do with that interest. And I had my mind open to going to med school or some pre-health type trajectory. And I met with the pre-health advisor at my university, and they asked me some question along the lines of, or they gave me some feedback saying that I had to want to be a doctor more than anything in the world. And I thought about it. I was like, well, there's no way I can say that. And so I decided, no, I'm just going to study biology and math and just sort of see where it leads. So that was actually very freeing sort of feedback that I got. And ever since, I've just pursued what I've been interested in. I've worked on a lot of different topics in biology and wound up in epidemiology. It's a place where I think there's potential to have an impact on people's health. And there's a lot of interest and data out there to inform the science that we do. So it's just something I really enjoy doing. In terms of the fun fact, I guess I'll mention some of my experiences as an undergrad. So I was really fortunate to have some nice opportunities as an undergrad to do research, but they kind of took me all over the place. It took me a while to figure out what I wanted to do. And so those experiences ranged from collecting spiders in the Everglades, all the way from winter to summer, doing field work at 10,000 feet plus in the Rocky Mountains on pine trees. So I really kind of did a bunch of everything before I settled on what I do now. So yeah.
Yeah, those are pretty good. Thank you very much. I think maybe our next section is rumor has it.
Yeah, so every week, Marianne and I hear from friends, family, and students myths or rumors that are being passed around in the community. And so we have a rumor for each of you. So Jenna, I'll start with you. Rumor has it that the virus is evolving to become less deadly because there are less deaths than there were at the beginning of the pandemic. Is this true or false?
Really tricky to say. So there is some evidence fairly recently that's come out that even after adjusting for age, that it seems like among hospitalized patients, they are getting better at treating people in the hospital who are coming in. So it seems like there's some suggestion that we're learning a little bit more how to deal with this virus and how to prevent deaths. So that's a good thing. It's definitely one good reason for flattening the curve and continuing to slow the spread of disease, because it gives scientists a chance to catch up with prevention methods and protection. And then there's also the real question that's difficult to tease out, which plays into Alex's research actually, which is understanding what the true denominator is. And in some ways, we need to make a distinction between what's a case fatality rate versus an infection fatality rate. So the denominator for a case fatality rate would be of all the people that have some sort of symptoms of the disease. Whereas if we're talking about the overall infection fatality rate, we're usually thinking about a denominator that's the total number of cases with the pathogen in their system, even if they're not sick at all. So including the asymptomatic cases. It's obviously a lot more difficult to detect that infection fatality rate and measure it well, because if they're not symptomatic, they're much less likely to get tested and diagnosed. And particularly early on, we weren't even doing a very good job of finding all of the cases that had disease. And so in some ways, without better data from testing early in the epidemic, it's hard to really say that things are changing dramatically in terms of the pathogen and its effect on people. But it does seem like once you're hospitalized, we're getting better at our ability to keep you healthy after and make sure that people are recovering.
Yeah, that actually brings me to the data that we have some data about hospital rates going.
Right. Yeah. So also each week, Marianne and I track the data locally and nationally. And so as I opened last week, I said, oh my gosh, it's been another incredible week of COVID data. And now here we are, and I'm saying the same thing. But here are a couple of the milestones that have come out for last week. Just this past Saturday, the country's 7-day average of new cases was 78,380, and that number has risen by 128% since early September. On Friday, the country recorded its highest number of recorded cases on a single day, which was 99,321. And this is also the highest of any nation on the planet. And then also on Saturday, the country recorded 47,374 COVID-19 patients in hospitals, and that is nearly 66% higher since early September. So each week I do just a short video, a 5-6 minute video talking about tracking the COVID data in St. Joseph County. And since we've started doing this, like, by the second week of September, so we've been tracking it, it's just this straight line going up, and the cases are increasing, and number of deaths are increasing. Also related to this is the increase in hospitalizations. In Utah in particular, the president of the state's hospital association has warned that within 2 weeks, they are likely going to have to start rationing care. El Paso has reached 100% hospital capacity and is setting up field hospitals now to handle the overflow. And in Michigan, hospitalizations have jumped up 80% in recent weeks. And it's a particular concern in rural parts. The medical director for the state, for their hospital association, said they are inundated with patients. So the pattern of the pandemic is really clear. Infections go up, followed by hospitalizations, followed by spikes in deaths. So as I say with every time we're talking, is that what's all of our role in this? And that's the public health message about wearing masks and avoiding the crowded places and spaces, hand hygiene, and of course, social distancing. So having said all that stuff about, the data and trying to understand these trends and so forth, Alex, I wonder if you could tell us more about how this informs modeling, or rather, before we go there, let's take a step back. Let our audience know, what is modeling? Why do we do modeling?
Right. So models, just a very simple way to define them, are a simplified description of a system. So examples that we use in our everyday life range from, let's say a toy kitchen that a kid plays with to sort of learn what parts are there and kind of how they work, all the way to a map. It's a simplified representation of a layout of things. So there's lots of examples like that. In epidemiology, models allow us to sort of tinker with a system and play out different scenarios without actually running them. So when a decision maker decides, okay, we're going to go into lockdown, or we're going to go into phase 5 of our reopening plan, or any of those sorts of things, those are very consequential things. And we don't want to take any more of a trial and error type of approach than we have to. So models allow us to sort of take what we know about the spread of a virus and the control of it and all of that, and put it into a little mathematical tool that we can use to explore the consequences of different options.
Wow. What kinds of things are you putting into a mathematical model?
Yeah, that's a great question. So we basically want to take all of the aspects of the biology that we think are important to the question of interest. So for example, if we want to inform a decision about reopening or going into lockdown, we would need to have in there different aspects of how people come into contact with each other and how different actions that we might take could affect their contact. We'd want to know how transmissible the virus is once people come into contact. We'd want to know who has a risk of being hospitalized or dying, depending on whether they get infected. So all those sorts of things that are relevant to sort of the inputs and the outputs that we're interested in, we would want to make sure we're representing as well as we understand them.
Wow,
So
complex.
can you guys tell me, either of you, there's like different kinds of models. There's mathematical models, and then there's simulation models, and probably others. Can you talk a little bit about those differences?
Sure. So there's a whole range. On the statistical end, we're often using a somewhat simplified description of, let's say, the relationship between an input and an output. Whereas with what's often called a mathematical model or a mechanistic model, we're often trying to represent the actual pieces of how the system works. So we'd actually want to represent people coming into contact and doing all the things that we think actually affect the transmission of the virus. And then a simulation-based model, often that's where we're getting into a lot more detail. So we might actually be representing specific individual people and having them do things like go to school and work and modify their behavior when they find out a family member is sick and all those things. So it's really just a spectrum of detail.
Okay.
Yeah, and I think it's useful to think about how some of our statistics that we use are somewhat static. We're looking at a relationship that we think doesn't change over time. But with infectious diseases, it's really important to consider change over time, because a person's risk is not going to be the same at the beginning of an epidemic as it is later on. So there's feedback loops that happen in these models that are really important to take into account. And it takes somewhat more complicated statistics to try and deal with those feedbacks that occur.
If you could just say a little bit more about that idea of an increase, that the risk is not the same at the beginning as it is in the middle, as it is towards the end of an epidemic. What does that mean exactly?
It's all related to that idea of contagiousness. We're talking about a virus where the number of people around you that are infected is going to be really important to how likely you are to become infected at any point in time. So when the total number of people in the population that's sick is still pretty low, the risk for all the individuals is fairly low on average, because it's only the people that they're going to come into contact with that are going to be at risk. But with a contagious disease, it depends how many people around you are sick. So as the virus is becoming more prevalent, your risk personally is going to go up, just because the likelihood that you'll interact with one of those infected cases is going to be higher.
Yeah, it's always very sobering,
Right.
I think. So what do you guys think? I mean, I know, Alex, you've done some models on COVID. So what do you think all these increases in cases and of the stuff that Heidi was mentioning says about our risk in the next few months?
Yeah, I think, we're almost at the point where you don't even need a model to do a simple extrapolation forward. All the trends are pointing upward. And so really, I think it's pretty inevitable that over the next few weeks, at least, that we're heading in a bad direction. But I think it's difficult to forecast beyond a few weeks out. Now, what happens in the next few weeks, frankly, is kind of built into the system already, because people who die a month from now are probably getting infected today. So there's not really a whole lot that we can do about that. But 2 or 3 months down the line, that depends very much on how people respond to this increase in cases and what policies are put into place, which has actually been one of the huge challenges with using models to forecast the pandemic. You heard a lot of very scary numbers back in March or so about millions of deaths and all that. And those, I believe, were perfectly plausible projections, but they were dependent on certain assumptions about how people would respond, how effective non-pharmaceutical interventions would be, all those sorts of things. But just the whole human dynamic is extremely difficult to predict. And that's not something that we're used to accounting for in models in this sort of a dynamic and complicated way.
Yeah, so how successful a model is really has to do with the assumptions that you make going in, I think.
Absolutely. It also illustrates, I think, the power for people's behavior in response to the pandemic to have a huge impact. We have not had 2 million deaths over the last several months. We've still had an awful lot, but it hasn't been as bad as it could have been, in large part because of how people have responded. So I think we as a society still collectively have a lot of power to keep this from being worse than it could be.
Back to the public health measures. Wear your mask.
Right. Exactly.
So the next section we have is we take questions from the audience submitted ahead of time. And so we had a couple of emails. And this one comes from Barbara Lynn from Mount Vernon. I'm assuming that's in Virginia, but I'm not sure. There's probably lots of Mount Vernons around. Anyway, it asks us about the Great Barrington Declaration. Yeah, and I actually had an email from my mother-in-law today asking me about the Great Barrington Declaration. So Jenna, can you tell us a little bit about what that is?
Sure. So the Great Barrington Declaration is basically two major concepts. So the idea of focused protection and the idea of herd immunity. And so essentially what the Great Barrington Declaration is arguing for is that we know that there's higher risk groups in the population, people with comorbidities of certain kinds, and people that are older. And so they're arguing that we should really focus on making sure that those people are isolated and protected because we know that they're at higher risk. But people that are at lower risk should be essentially doing nothing and trying to get the disease in some ways so that there's more immunity in the population. And the idea would be that ultimately a herd immunity protection would exist to drive the cases to zero so that everything can go back to normal. And it's complicated. So one of the things that I think is important to explain is what the concept of herd immunity actually means. And so I like to think of it as a distinction between personal immunity, which is what we would traditionally think of. You've had a vaccine or you've had an infection, and that means that you, even if you're exposed to a disease of some kind, are not going to get sick from it. So some sort of personal protection. Herd immunity, on the other hand, refers to the idea that there are going to be some people in the population who aren't personally protected. They, if exposed, would get sick, but there are enough people who are personally protected that the virus or bacteria sort of dead ends. And so it can't spread enough to infect those people. So they get herd immunity from the herd. They're protected to some degree as a buffer, but if they're exposed, they're not personally protected. They're just probably not going to get exposed because enough people are immune. There's a lot of assumptions built into assuming that strategy can work. One of them is that infection with COVID-19 is going to lead to a strong and long-lasting immune protection for the people that are infected. Which, you know, there's some questions about that. It may or may not be true, but it's a lot to rely on that as our primary method and strategy at that point when we can't say for certain that that's going to be the case. And then it also implies that we really do understand the groups that are at low risk and that they are at a truly low risk where, you know, there's pretty severe cases that are happening. Even if they're not leading to deaths, there are pretty high rates of hospitalization, really long chronic impacts in younger populations. And so, you know, as much as there are populations that we know are at high risk, there's also a still pretty elevated risk associated with getting the disease, even if you're not in the known high risk groups. So that's a challenge. And then one of the other problems that's brought up with this is, can we actually fully isolate? So if the disease is running completely rampant in young people, are we actually able to stratify our society in such a way that no one's going to get exposed? Yep. And I find it difficult to imagine that that's going to be possible, because even with what we're doing now, where we're trying to protect as many people as possible, we're still having the virus spreading a lot. So I don't really see how a policy change where we're going to have more people exposing one another is going to help stop the spread of infection in some way that's going to actually protect the oldest and most at risk. We're just not stratified in that way. And then the other problem is, if we've got herd immunity for the general population, there's not herd immunity in like a nursing home. If they get an introduction of the virus there, it could spread like wildfire. So herd immunity really has to mean that everyone's got a distribution of immunity in the people around them. So pockets where it's heterogeneously mixed in terms of who's personally immune, those pockets are still going to be under threat unless we can do something about it. So those issues. And then also it implies that there's not a benefit to dragging out the number of cases, whereas we've seen we're getting better at dealing with it. There is going to be a vaccine eventually. So how many cases do we really need to have before we get to the point where we can do a better job at protecting people from actually suffering from the virus? So it's a complicated question for sure.
For sure. If I might, Alex was talking previously about when you're developing a model that assumptions are made. So in this, the Great Barrington Declaration, the assumption that's being made is that you can, in fact, as you articulated, that you can isolate the high-risk population and allow the low-risk population to run around like normal, right? But correct me if I'm wrong, because I didn't read it as carefully possibly as I should have. There was a University of Wisconsin study where they actually studied the genetic material of a virus that was isolated with college students, and were able to track it to a nursing home. Is that correct? I believe I read it like that. So what that tells us then is that there is a connection. So this assumption that we can somehow make sure that these things stay separate, I'm not buying it. So I guess the question for me is, why do the folks who are signing on, because there's quite a few people who've signed on to this, right? Why do they believe it will work? If we're sitting here saying, I'm convinced that that doesn't work. Why do they think it does or will?
Well, I think you'd have to ask them. I've actually signed something else known as the Jon Snow Memo, which is really sort of a response to the Great Barrington Declaration, which has been signed by, I think, around 7,000 scientists at this point. I think a lot of the motivations come from, concern about the economic and social impacts of lockdown and school closures and all those things. And nobody wants to see those things happening. I mean, those are
Right.
extremely costly measures, and we want to get out of that situation. I think the response and the criticism of the Great Barrington Declaration, a lot of it is based on, this sort of being a false choice. There's nothing that prevents us from trying to protect the vulnerable and to try to suppress the virus at a population level. So it's really sort of a false element of this Great Barrington Declaration to say that, we kind of have to go this way in order to protect the elderly. A couple of other problems with it I'd like to point out, though, given the opportunity. One is, think about healthcare workers, frontline healthcare workers. If we just let this virus run rampant, even if somehow we magically protect the elderly, we're still going to have plenty of people our age in the hospital, plenty of those people dying. It's going to be completely overwhelming. Like Jenna mentioned earlier, this is not just some linear phenomenon. There's exponential growth involved. And so this would completely overwhelm hospitals. The situation you mentioned in Utah, Heidi, about having to ration care and prioritize, that would be the standard across the country if we went through with this. So it's just the consequences of this. I don't think people can really fathom how bad this could be if we just let the virus run rampant, even if we manage to protect the elderly. The way I like to think about it is that, we want to minimize the cost of these things like shutting down the economy and shutting down schools, but we have to make priorities. Clearly, I think everyone would say that it's really important to get kids in school. Well, to do that, we need to not just shove them into the school, we need to make it safe by getting community transmission down. And we have to ask ourselves, is it more important to have kids in school or to have bars open? There's a lot of choices like that we need to think about as a society, and we need to really sort of make some priorities. No matter what, we're in a terrible situation, but it's not being imposed by one side of an argument or another. It's being imposed by the virus, and it's forcing us to make, sort of choose from the least of a set of bad options. So.
Yeah. Well, you guys, thank you very much for enlightening us on that. So we did have another question that was posed actually the very first session that we had, and I've been saving it just for you guys. And it is from John H. And he asked us to comment on the applicability of the Bayes theorem to interpret diagnostic tests. So Alex, can you tell us what that theorem is, and can it be used for this?
Yeah, absolutely. Bayes' theorem is very central to lots of things that we do in epidemiology, including interpreting testing data. And while I could go on the marker board behind me and sort of sketch it out and do all sorts of math, I'll refrain from doing that.
Thank
I
you.
think that the thing that I would like to get across is that Bayes' theorem is basically something that helps us relate different types of conditional probabilities. So a conditional probability, I think we're all, kind of have an intuition about what probability is. If we flip a coin a bunch of times, how often does it come out heads? Well, a conditional probability is the same thing, but it's conditioned on something else happening. So in the context of testing, you may have heard of terms like sensitivity and specificity. So sensitivity is that given someone actually has COVID, what's the probability that if we test them, that the test is positive? So notice that probability, that's not just saying, well, what's the probability if we just go test a bunch of people that they're positive? It's the probability that conditional on them actually having it, what's the probability that the test is positive? Well, that's a useful thing to know. It's really important to understand about our diagnostic tools. But on the other hand, there are times where a different type of conditional probability known as predictive values, so there's either positive predictive value or negative predictive value. So this is more along the lines of the probability that someone really has COVID given that they test positive. So we sort of flipped around the conditioning there. And those are two different types of conditional probabilities they're different. They have different meanings, different ways of measuring them, different implications. And Bayes' theorem just basically helps us relate those quantities to each other.
And so you're saying that it is used often in interpreting diagnostic tests.
Yeah, and just to mention the positive predictive value, this one is something that comes up a lot. So again, that's the probability that someone really has COVID given that they've tested positive. One thing that's different about the other type of conditional probability, the sensitivity, is that this predictive value depends not just on the test, but on what's going on in the population. So it depends on the prevalence. And in general, we'd like to be in a situation where we have fairly low prevalence of active infection at any given time, which means that the vast majority of people out there, and even the majority of people that that come in to seek testing, tend to not actually have COVID. So the fact that overwhelmingly we have more people who really are negative, that means that a lot of our positive tests are going to be false positive. Even if our test is very accurate, just because there's so many negatives out there, even if we have a few, they're going to add up and sort of overwhelm the true positives in some cases.
Well, so this actually brings me to the headlines, because the headline that we're highlighting this time is from the New York Times, and it's, "Is your state doing enough coronavirus testing?" And so I know that you guys think about that. There's different kinds of testing strategies, right? Could you guys talk about that a little bit?
Yeah. Well, one of the things that I think started taking on a huge importance in people's minds at the beginning of the epidemic was the test positivity. And in some ways, that metric is really just reflecting how much testing is being done. And if you've got a huge percentage of the tests that you're doing coming back positive, what it really means is that you're not doing enough tests to find all the cases that are out there. So if your test positivity is really low, but the total number of cases is still high, you still have a problem, even though you're doing enough tests. It's just that your data is probably better quality than if you had a high test positivity. And so, yeah, the test positivity is more about the quality of your information, whether you're having enough tests done in the first place. In terms of thinking about types of tests, maybe I'll let Alex handle that, but I did want to add sort of on the Bayes' theorem discussion that the priorities of the type of testing that you're doing can change what you want to value in a test. So if you often make a trade-off between sensitivity and specificity. So to make sure that you're finding every possible case, you probably are going to have more false positives, but you're not going to miss anybody that actually has it. So a high sensitivity test might trade off a lower specificity. So if we're doing diagnostic testing for people who have active symptoms, we think that they probably are going to have higher densities of the virus. And so you don't need the test to be as sensitive to diagnose those people if they're coming in with symptoms and you're testing them in a clinical setting. Whereas when we're screening the general population, if we're trying to find every case that's out there, then we might want to be using a test that will trade off what's the cost of a false negative. So we want to make sure that we're finding everyone and maximizing our sensitivity, but not misdiagnosing anyone. Then at the same time, you could be thinking, if we're just doing wide scale enough screening, it's okay if we miss a few cases. If we're retesting every 2 or 3 days, we'll find them later. So we could give up a little bit of sensitivity if we're testing often enough. So what you're looking for in a test depends on how you're planning to apply that test in a population. Alex, I don't know if you have follow-up on that.
Yeah, I think those are all really good points. A couple other things I might try to touch on are sort of how you use the tests for different goals and things like that. One misconception that I hear a fair bit is if we're thinking about vulnerable populations, I think there's this idea that, oh, we need to test them a lot. Well, there's nothing wrong with that, but we actually need to test the people who are going to potentially come into contact with them, because once you're positive, there's not really a whole lot you can do about it unless you become severe and need care. But what we really want to use testing for is to identify cases and to do so early in their infection so that those individuals can isolate themselves and prevent onward transmission. And that's why when you hear about things like delays in testing, my wife and I got tested over the summer. Thankfully, they were negative, but we had to wait around 2 weeks before we knew that result. And, that was practically worthless. We were able to isolate ourselves regardless of that. But in some situations, people can't do that until they have a positive test. So we really need to make sure that we're getting tests out there to everybody, regardless of whether they think they're vulnerable or not, because that really affects how it spreads to others. Another thing is that in certain populations, you may have sort of different goals for testing. So one good example, I believe that in a week or two, you have someone from the University of Illinois on this series. Mm-hmm. Is that right? Yeah. So an approach that they have taken at their university is to test everyone on the campus twice a week, I believe, regardless of any symptoms or anything else like that. And again, the reason is not because they think, they want to protect this person or that person, but they just want to be able to catch people early in their infection. And the only way to do that really is to just test people very frequently. And so in settings like a university or a workplace where that people are going to be engaged in contact and that once it gets in there, it's harder to control, a really good way to mitigate that or prevent that from happening in the first place is to make sure that infections don't get in there. And really, there's no substitute for frequent testing.
So why aren't we doing frequent testing in our local community, in our state, right? Remember in the beginning, it was very much rationed that you had to be high risk, an essential worker, right? And now I think we've increased the definition in terms of who has that eligibility. But if I didn't have symptoms, but I wanted to go get a test, I can't just walk up anywhere and get a test. Am I right? Or has that changed?
Not sure. It probably depends on the location and who's providing the testing. It might differ from place to place. I'm not even sure.
But I think it holds true though that as a state and as a community, we're not just encouraging everyone to go get tested. Is that correct?
Not as far
right.
As
so yeah, that's.
Well, and I think when you're talking about the whole of society and the whole of a county or state, it's a little bit, it's just a massive scale to think about testing every person in Indiana twice a week. Whereas within the context of a university or a workplace or something, that's potentially more tractable. So I think that's a starting point, but really there's no such thing as too much testing. I think there has been some scale up in the federal government in terms of increasing the number of tests that are available and things like that. But we still have a long way to go to get to where we need to. I mean, what I would eventually like to see is that, what if everybody in the country had a test that they took every morning before they went off to work or school? It's just a quick, little paper test. And they just, if it was positive, they're like, oh, well, I'm just going to, stay in today, see how things develop. That's sort of the holy grail ideal situation, but we're just so far from that we have to, I guess, think in a little bit more of a targeted way.
Until capacity is sufficient, we have to strategize a little bit better about who can get the limited number of tests.
Right.
Yeah, I think ultimately a lot of people are trying to develop these lick-a-stick tests that you could do at home inexpensively. Part of it's getting that cost down. So actually, when something that was in this discussion reminded me that we are at time where we take questions from our audience. And what reminded me is there are two individuals. One is Laura Batt, and the other is Taryn Dinkelman. They're asking questions about surveillance testing in our local schools. And, would that be something that would be feasible, like in our K through 12 schools, and why we might not be doing that. And I remembered that, Alex, you did some modeling on the K through 12 schools and thought maybe you would have an opinion if that would be helpful.
Yeah, so I mean, the short answer is it would absolutely be helpful. If you prevent kids or teachers or staff from showing up who are infected in the first place, that would be a crucial thing to eliminating the possibility of transmission within schools, or if you catch them once they're in schools. And I mean, it would certainly be hugely beneficial. We have not considered it in the modeling of schools that we've done, just because I haven't really been hearing it as something that's really being seriously considered in a lot of places in the US. There are others who have modeled school reopening who have looked at testing with some sort of regularity in schools as a preventive measure to try to identify infections. And they've certainly found a benefit of that. So even though we haven't looked at it directly, I'm very supportive of it if it were at all feasible. And I think it would certainly make schools safer to do that. Yeah,
I'm guessing we already have trouble with especially our public schools, the budget's being cut so dramatically that we probably can't afford it.
And, just to add a little bit to the conversation about the schools, because it comes up every week about what we're doing to protect the schools and so forth. According to our local health department, the contact tracing is not providing any evidence that there is just widespread transmission in our schools, and that in fact that is very, very low. So we keep our fingers crossed that they are doing the right things and doing all the prevention work. I too would like to see stepped up testing. I think it's essential. I'm not sure why we haven't prioritized that yet. It seems like something that should be done, but anyway, we've got lots of other questions. You guys, as we're talking, they're typing really faster. Right, exactly. So it's awesome.
So I'm going to take this one. Edward Kukla, I believe, as a biologist, he has a master's in science and biology from the University of Notre Dame, and a mathematician. He also has a master's in math. I am concerned about the data from government websites. Since my mom is in a care facility in your area, I was worried when she came down with coronavirus. She's better. We're very thankful that she's better. But the Indiana website does not seem to indicate that there is a hotspot in northern Indiana. Can I trust the statistics? Is the sampling suspect, or is the analysis being modified? Which sites have the best data, be it governmental or non-governmental? That's a tough one. Thoughts?
Yeah, that's a tricky question. So in some ways, Alex's data pointed out that we know we're most likely underestimating. Especially earlier on, hopefully we're underestimating less, but the more cases there are, the harder it is to keep testing everyone. So I think that's a general limitation, even if you're not trying to hide anything. We just need lots of testing to have good data. So there's that. I find that in general, I'm just trying to look at as many different sources as I can to get a good understanding of what's happening, because every different source is going to have limitations of some kind. So yeah, it gets harder the more specific an area you're trying to get information on, because you end up having fewer options for sources of data. And I don't really know that there is a way around that. But yeah, I don't know about conspiracies to hide data. I don't have any insight about that. It's if it exists, that's a real shame. But I think the biggest problem is that testing capacity still has to be on top of it. And if people aren't getting tested, we just don't have good data to know. So that's an issue. But yeah, otherwise, just looking at lots of different sources and getting an idea of what the range of estimates are is really what I'm trying to do when I'm looking around.
Yeah, doesn't the Indiana website break it down by county, I think?
It does. It does, but the data doesn't always line up nicely. There are delays in data reporting, and then even sometimes not everything gets reported. But what people, our audience, what I want to say about that is that we have a really weak public health infrastructure in this country. And so and that includes the data infrastructure is very weak. So it's not surprising that these things don't always line up exactly. And what I would say is, if you want to know more about your local data, I would be contacting the local health departments, because they do have their finger on the pulse. Here in St. Joe County, they get that information directly from the folks, the directors and administrators who are running these facilities. So I feel fairly confident of the data that the health department has on their website, and they do about daily press releases, and then they do a one time a week, a case summary. So it includes those nursing home data, and that's posted right on their website. As a follow-up, I was just wondering, Alex and Jenna, what are your go-to sources? Like, do you wake up in the morning, get your coffee, and you're like, let me check these 3 sources? Where do you guys go to get your intel on what's going on?
Yeah, so I definitely look at the Indiana Department of Health website, and then the Regan Street Institute has a kind of similar but complementary website. And I think that's pretty detailed and pretty good. I think Indiana's done a pretty good job compared to a lot of states in terms of the transparency and detail of their data. Certainly Johns Hopkins is famous for their website now, the New York Times. There's another organization, I can't remember the name of it off the top of my head. It's something like coviddata.org or something. I just tried to look it up. That wasn't it. But they've done a lot to not just count up numbers of cases and deaths, but also to sort of gather up information about testing efforts. So how many tests are being performed, which is really important, because when we look at just trends in case numbers, that's a function both of trends in what's going on with the virus, but also trends in how much testing is happening. So that's something I really try to account for if I'm going to try to make sense of case numbers. So.
Oh, that's good. I hadn't heard about that website before. I'd like to know more about that. And Jenna, you were just talking about that we have to understand the denominator better. What are your go-to sources, Jenna?
The ones Alex mentioned are good ones. And then sometimes I'm just checking Google to get a feel for the trends over time. Just Google COVID deaths today. And, it gives me an idea. I'm not looking generally at super specific. I'm also checking the Notre Dame's dashboard every day, keep track of really specifically, because at this point, I'm staying in my home as much as humanly possible. And the only time I come to campus is to walk into the classroom, stand at the front of the room and leave. So the risk factors that are the most pertinent for me are how many cases are happening on campus right now.
Right.
So I'm keeping a close eye on that every day.
I just want to add, I found the name of that website I was referring to. So it's covidtracking.com. And I think that's a nice source of information. One other thing I'll just mention about that, this is just a group of people who got together in the spring and put this together basically to fill a void that was there that was not being filled by the government. So I think it really just sort of underscores what Heidi said about the lack of public health infrastructure in this country. And I think, the elections tomorrow, all this stuff is on people's minds. I'm hoping that once we get past that, we can really focus on trying to make some really serious investments in this, because this may well not be the last pandemic within many of our lifetimes.
Right. Wow.
Yeah, I think that's definitely right. So we do have a a comment from Marie Donahue. She's also in the Eck Institute for Global Health. And we've been talking all about this testing, but she said to remind us not to forget to mention contact tracing along with testing. So it's not just testing, it's finding those contacts and then testing them. So that, I thought that was an important comment. So I'm looking through all of these questions. Here's one from Harry Souza. Does Alex's model account for structural bias about access to normal care? For example, poor people are dying and experiencing worse outcomes. So I guess this might go to some of the heterogeneity in risk, maybe that Jenna was discussing. So do models account for that?
Yeah, so in my models, we haven't accounted for that explicitly. I can't think of too many others that have. I certainly agree that that's an important point, but the difficulty is to try to account for that. We need to have some information about what those biases and inequalities are. And like the viewer mentioned, that exists both in terms of access to care or maybe willingness to seek care, but also in terms of exposure. I think a lot of people who are less well off are forced into positions where they're exposed and maybe don't have care to support them once they get it. So it's kind of a double whammy, and there's a lot of those things that we would ideally be accounting for.
Okay, so actually another comment from Joseph Dietz, and he suggests that the best website is from UW and Microsoft. Includes projection methodologies, COVID-19 healthdata.org.
Good to know.
Yeah, I thought that I would pass that on. So here's another one about from Marie Donahue. About 11% of undergraduates have tested positive for coronavirus on our campus. The WHO considers less than 5% one indicator that an epidemic is under control in a country. What does this mean for our campus?
Well, yeah, I think that it is definitely important to think about how institutional settings have particularly dense contact networks. And so living in a dormitory, you just have a lot more contact with people. If you're eating in dining halls, if you are socializing a lot with your friends, that's very different than my situation where I go home to my house with my dog and, I'm just not seeing as many people, and most people going about their day-to-day lives aren't interacting with as many people as students on a college campus do. So it's certainly true that in populations, there's going to be these pockets where there's really intense likelihood of high spread of disease, high reproductive numbers on a college campus. And that's borne out over this semester, especially when we saw that almost immediately on returning to campus, we had a quick spike in the number of cases. And to be honest, I think that we owe so much to our students this semester for it not being worse than it was, because you look around campus, people really took the messages of needing to wear masks and needing to stay outside as much as humanly possible. I think we could have seen it continue like it was the first 2 or 3 weeks, and essentially everyone on campus could have been infected by the end of semester. So in a dense contact network like this, it can easily become much more of a problem. So credit to the Notre Dame students for turning things around to a large degree. Now that it's getting colder and it's harder to socialize outside, I think the pressure's on again, and people are tired of having to put up with these rules and restrictions. And I think in the winter, it's gonna get harder and harder. And so it's really, it's gonna be a challenge as we move forward.
That might be the perfect segue into maybe just the last question, and that is, So as epidemiologists, and based on this conversation that we're having, what advice then would you give to your family and friends about the next several months? You know, what's your recommendation to us to keep ourselves safe?
Yeah, I mean, to me, it's all about reducing your contacts with other people as much as you possibly can. And so for those of us that need to have some sort of socialization that's in person over the holidays, I like the idea of those bubbles or pods where you've got your group of people and you're just sort of a monogamous pod. You're not going to interact with other pods. You're just going to interact with one another. And then you cut down as many of the external exposures. Like I'm starting to get my groceries ordered for curbside pickup so that I don't have to go into any stores. And then other than that, just spend time with my family and no one else as much as we can.
Yeah, and just to add to that, I would say that people should just make whatever adjustments are within their control. Certainly wearing a mask is within your control. Choosing whether you go eat inside at a restaurant or get takeout, choosing whether you do the curbside pickup of groceries like Jenna said, or whether you kind of wander around the aisles looking for inspiration about what to cook for dinner. So, and likewise, you know, as the holidays are approaching, even though we all always look forward to seeing our family and going to Christmas parties and all these things, you know, I think people need to give some of those things a second thought this year. And even though that's hard to really think about, I think no matter what, we're in a period of adjustments and making compromises. And, you know, when we can substitute things, you know, to the extent that you can visit people online or do other things, I think we need to try to do that.
Awesome. Wow. That's good advice, you guys.
Yep, great
We
advice.
need to segue and wrap up, don't we?
Yep.
Do we have time for one or two fun questions? Maybe just,
Yep, yeah, I think let's go through our lightning round.
oh, good. Okay. I'll go first with the first question. So we have this lightning round. We're going to ask you some like fun questions and get your response. So Alex, I'll start with you. What is your superpower?
Well, it's not that great of a superpower, I guess, but I sort of make up and improvise a lot of songs around the house about our family. I'll just kind of get a tune in my head, and my wife thinks they're really good, or at least she tells me they are, but my kids are pretty annoyed by it. So.
Are you going to share one?
No, maybe after the pandemic, you can come over to my house sometime and you'll keep singing.
That's awesome. Jenna?
This is pretty outdated now, but after one summer of being stuck at home for a month with nothing to do, I am really, really good at Minesweeper. Crush it.
It's good superpower. Okay, Jenna, what's the last show you binged and loved?
I've been re-binging The Great British Bake Off lately. It's just nice people being nice to one another and making beautiful things, and it's kind of soothing to the soul. So that's been fun.
That's a good one. Alex?
I would say probably The Curse of Oak Island. And this is very nerdy, but one of the things I really love about the show is that there's this treasure buried deep below the surface that they can't actually see or get their hands on. So they have all these little clues that they see on the surface, and they try to piece together what's going down underneath. That's exactly what we do with modeling. We don't see exactly how many people are infected or what's going on with the pandemic, but we get all these little glimpses of it. We try to use these theories to piece it together. So I honestly love that aspect of it.
That's
yeah,
awesome.
it is a little geeky, I think.
I was going to say just a tad, but that's awesome. And so, Alex, what is your most treasured possession?
Right back there, the marker board. I've been working from home, and so I couldn't resist. I had to get one and install it in my house. I have them all over my lab. It really helps me kind of think through stuff and just kind of, you know, get things out of my head and onto the marker board.
That's awesome. Jenna?
I don't know if it counts, but my new dog, if she's a possession, she's really helped me survive quarantine. I adopted her in May, and so much better having her around.
That's awesome.
What kind of dog is she?
She's a St. Bernard mix, so she's a big old girl. She's about 110 pounds.
Oh, that's great. We just got a new puppy, an English Mastiff.
Oh.
She's a baby. She's only 9 weeks old now. So just quickly, Jenna, what are you deeply grateful for right
Oh gosh. I mean, I'm really grateful for the fact that we have the internet right now. I can't imagine what I would be doing if I wasn't able to go online and have access to all my friends and family at this point in time. It would have been so much worse.
Yeah. Alex?
I'm really grateful for the fact that my self and my family are safe and healthy. I have my job. So, even though this pandemic is inconvenient, we're in a much, much better situation than many people are. And I'm very grateful for that.
Yeah,
Awesome.
me too. Thank you so much. And thank you both for joining us. It was a fabulous discussion, and we'll probably tap you to help us answer some of these questions that we didn't get to. And I want to remind everybody that if you have any suggestions or future topics, please email us at consider@nd.edu. And we hope that you tune in next week when we will consider wastewater testing with Dr. Kyle Bibby from the College of Engineering. So consider this: the more you know, the more good you can do.
So be informed and act on accurate information.
And share reliable information with others.
Until next week, be kind and give grace to each other. Bye, everybody. Thank you.